Yes.
Thank you.
You come from time to time.
Yes, regularly.
And you're still sort of very hands-on at Mater Dei.
Well, no, I think Mater Dei doesn't need me, but cardiology, Dr. Jureb is very nice, and I have my colleagues and friends there, and I think I'm very lucky that they still invite me to come to the clinic.
I think you're lucky to have each other. I'd like to go back to 1968. We've got a lovely photo.
Oh, dear.
Because you were the physician who was chosen to participate in that very famous operation. Can you tell us a bit more about it?
Oh, goodness, yes. I remember that night. I was running around like the handmaiden to the cardiac surgeons. There's Donald Ross on my left. And they organized the first cardiac heart transplant in London. And it was very exciting. And I was to look after the patient. Of course, I didn't know anything about it at all, but I ran around after the surgeons and everything. It was very exciting.
I can imagine it was very exciting. Your patient, somebody called Fred West.
Lovely, courageous man with terrible, terrible coronary disease. Mm-hmm. And terrible heart disease. And he was the right man, actually, to have a transplant. And it should have worked. Mm-hmm. It was very bad luck. But it failed for two reasons. Firstly, there was a technical mistake by leaving like an extra appendix in the heart. And but we didn't know because this was the first. And also because we failed to diagnose that clots were coming off into the heart, from the heart into the lungs. Mm-hmm. And we just failed to make that diagnosis, which is very bad. You could say that that was me, inexperienced, but it was very exciting.
Yes, very exciting.
Oh, terribly exciting.
And you obviously went from strength to strength in a very male-dominated environment, as we've discussed before. And what made you come up with creating the Gooch? Because, I mean, you're world-renowned for that. You still travel around the world?
A bit, yes. I'm less interested in long-haul flights.
Yes.
Traveling is not as much fun as it used to be. But, well, what I came up with it was because I had to, because I failed to get a job in cardiology, and I failed to get a job in pediatric cardiology because the pediatric people wouldn't have me, because I wasn't one of them. I was trained as a cardiologist, even though I knew quite a bit about things you were born with in the heart, but they wouldn't have me. So I never got on the short list of any job, never got interviewed. So I remember coming back from Great Ormond Street, where I was also working, in the car, and I thought, I'm going to create my own specialty, and I will be the only one they can appoint if they want it. I can remember exactly where I had the thought. It was in Tottenham Court Road, in the traffic, before I turned left to go back to the heart hospital. Yeah. And I thought, well, I'll create my own specialty. And that's how it happened.
And what year was that?
Oh, well, it was about in the early, it was about this stage, sort of around now, because it was clear to me that this great cardiac heart surgeons, that all these patients were going to come back because they'd only half done it.
Yes.
If they lived. Yes. I mean, in the 1950s, when I was a house officer to a cardiac surgeon, very famous one, we were lucky if the patient survived. Mm-hmm, mm-hmm. I remember out of the first 10 blue heart children that were operated on, only one survived. Mm-hmm.
And basically that's why you had to create the speciality.
Well, in the survivors, they left a lot of abnormality.
Yes, yes.
So I was intrigued by that, and I thought, well, I'll look after the grown-ups.
Yes. But more children were surviving and reaching...
by the time the 70s came and the 80s, many more. And so now, over 90 to 95% of children operated on in childhood in the very best centres and countries that have it well developed will now survive to adult life.
Yes, and that's why you need the speciality. That's why you need it.
We do, because there are actually more grown-ups born with heart disease than there are children. I mean, the children's doctors don't like to know that figure because there aren't more doctors to look after the grown-ups, but there are more grown-ups in all the countries that have developed cardiac surgery.
Yes, yes.
And you might ask me why there are enough in Little Malta. I mean, I think that's...
Absolutely, I was coming...
with only 500,000 people here, or whatever your population is.
We're growing, we're growing.
Well, you might ask still why it justifies a service within your excellent Department of Heart Diseases. And it justifies the service because 40 years ago, your very wise doctors here said they didn't want heart surgery for children because you didn't have enough babies born with it. So they sent them to the best centre in the United Kingdom.
In the UK, yes.
Mostly to Great Ormond Street, other centres a bit. So you got a lot of survivors back because you chose the best surgeons.
Yes, yes.
So you've got a lot of survivors.
And those survivors need the speciality which you have created, which...
Well, because it is true that most of these conditions are not, as the surgeons like to think, totally corrected. That's a dream of cardiac surgery. It's very rarely a dream that is met. And these patients have things as they pass adolescence and into adult life, and now surviving to 70 or 80.
That's amazing. You know, we have a lot of medical features on this program, some very innovative. We also film a lot at Mater Dei. And this program is also seen by a lot of medical students, young doctors, nurses. So we chose, I hope you don't mind, four slides. And perhaps you can explain the technical details if we can see them.
If I can,
yes,
I will.
Yes,
if you can. If I don't know, I shall say.
Yes, yes.
Right. We don't have a pointer, but as you see, there's a hole in the wall that you're looking at. There's on the side is a... You don't have anything one can point with?
No, we don't, no, but we can describe it.
Well, you see that there's a hole.
Yes, absolutely.
Looking at you.
Yes.
That is called an atrial septal defect and is one of the common things that occurs. Isn't the most serious hole in the heart, but it's there and it does overload the right side of the heart and it does cause problems, not usually in childhood, just occasionally if it's very big. And it needs to be closed.
Does a hole like that ever close up on its own, of that size?
Exceptionally rarely, but strangely, we saw a case in the outpatients I did with Dr. Caruana that had closed a hole like that, but it's usually a hole in another place, lower down, that can close, lower down in that pink bit.
Yes.
Where you're looking at the right side, inside the right side of the heart, and you see that pinky one, they've coloured it differently, which makes it easy. But when you get a hole in that wall you're looking at, straight on, that can close spontaneously, and most of them do.
Okay, and that hole that we're seeing, what age would you recommend an operation?
On what?
On that hole.
When the child presents so that the right side of the heart is overloaded, that's not one that needs to be done in infancy, usually.
So once a child grows up a bit?
Well, say after a year or two, and it should be done without complication. But now things have changed. We can put in an umbrella in a heart, in a hole like that. And they put that in through a tube so the child doesn't need an operation at all.
Oh, that's amazing.
And this can be done in Mater Dei, and my colleague Joe Di Giovanni, a Maltese who's worked in Birmingham, comes and does it for you still.
Lovely, lovely. And can we see the other ones? We're giving you a lot of work today.
I don't mind, I'm used to it.
Yes,
it's easy.
We can have a look at the second side.
Now those are holes, as you see, in what we call the ventricle, or the pumping part of the heart. And you see all those black spots we were talking about. They are holes in different parts of the of the wall between the two pumping chambers.
Sure, sure.
And depending on the size, they should be closed. Some of them will close themselves with nature. Some of them will cause other troubles in the valves that they are nearby. Mm-hmm. Some of them will cause no troubles. Mm-hmm. Some of them will make a loud noise, like some people, and not be of any importance at all.
Yes, yes.
So I can't tell you, it depends. If they're big, they need closing.
Should I assume that this is less severe than the first slide we saw?
No, this is more severe.
More severe.
If they're big.
Mm-hmm. Okay.
In fact, if you look at the part we were talking about before, mm-hmm. where the right chamber you're looking at end on in the brownie section, that one,
yes.
back to the slide you were showing me, mm-hmm. you see that hole is not there and looks as if it's been closed.
Yes, yes, absolutely.
Either by a patch, but now it can be closed by an umbrella and doesn't need an operation at all in 70% of the holes mm-hmm. in that wall.
So I would imagine it's close monitoring of each patient, right?
Well, you've got to, first of all, diagnose what is in the child accurately, and this can be done with modern technology. Mm-hmm. Then you've got to decide what you've got and whether it needs treatment at this stage or later on, mm-hmm. or whether it will be of no consequence to the patient's life mm-hmm. at any time. So you've got to, or whether one day it might get an infection on it.
Yes.
That hole we looked at first time
yes.
doesn't get infection. Those little holes we saw in the pink part do. So it requires a bit of knowledge with the children's heart doctor, and you have an excellent children's heart doctor here, really good. He also had the wisdom to realize he didn't want to look after adults, mm-hmm. which helped me come here. Mm-hmm. Mm-hmm. He wanted it. Yes. He was wise.
Yes.
Thank you, Victor. I'm ever grateful.
He comes quite regularly to this program, yes, so our audience know him very much.
Oh, he's great.
Yes.
You're lucky to have him, actually.
Yes, absolutely. And can we go on to the third slide, please? We're getting you to work hard here today.
Well, not work hard. This is easy peasy, as my children would say. Easy peasy. Well, actually, that's a diagram of, if you look, the top blobs, the right receiving chamber and the left, the top ones. Look at them first.
Yes.
And you can see that the blood, when there's a hole in the top part that we looked at with that whole end on, goes from the left side where the red blood is to the right side, pours over, because the right side, the blue side, is more stretchy. And it almost sucks the blood from the left side, and that overloads the right side, and that's why we have to close it at some time, and ideally in childhood.
Yes, yes. And on to the next one. We've got a couple more, if you don't mind. I'm sure people will find it...
if I do mind, it doesn't make any difference. They're still
no, because you're here now, exactly.
That's life. I'm used to that in the outpatients of life. Now, well, that's rather funny. Oh, yes. On the right side, look at where it says tetralogy of Fallow.
Yes.
Now, that's the commonest blue condition you can be born with.
Okay.
And it's unusually common, I think, here in Malta. I think you have probably more than we do, but I'm not sure the incidence.
Is there any reason for that?
Oh, I don't know. I don't want to get into it. First of all, we have to know if my impression is true or not.
Yes.
And you better ask Victor.
Yes.
There could be reasons, yes, but I don't want to get into it. Now, if you look in this complicated diagram on the right, it's very hard on the viewers. I'm sorry, they did it, not me. But if you look at the pumping chambers, that's the lower chambers that are thick, you'll see there's a hole between that wall, the wall.
Yes.
You see in the middle?
Yes, yes.
And the blood is going from the left to right. But in this disease, because there's a narrowing on the way to the blue artery to the lungs, you see the blue are the arteries to the lungs that look like a T-junction.
Yes.
Those are the arteries to both lungs. If you look up that channel, and we don't have... By the way, if you do this again, ma'am, you deprived a pointer, because the poor viewers won't see. Now,
but you're explaining
as you
very
go
well.
up the channel, you see there's a narrowing, a bar of muscle.
Yes.
And that narrowing makes the blood not go from the left to the right, but from the right to the left.
Yes.
Out
So it
into
needs
the
to be
body,
corrected.
out into the body without collecting oxygen from the lungs.
Mm-hmm.
Therefore, the patient is blue. If the narrowing is very severe, the child will be very blue soon after birth.
Mm-hmm. Mm-hmm.
Depending on the degree of that narrowing, which comes in all shapes, mild, moderate, or severe, you will depend on how blue is the child and how soon it needs help.
So interesting. It's amazing. It's an amazing topic, I think.
Well, that was the first blue thing to be, condition to be operated on anywhere in the world. Mm-hmm. And I'm happy to say a woman thought of the operation that should be done, not a man. Dr. Helen Taussig in the 50s.
Right.
No, in the 40s. They did the shunt outside the heart when they couldn't get in.
Yes, yes.
Now we repair it from the first time and early and in infancy and so forth.
We wanted to touch a bit on the subspeciality of Gooch and oncology.
Oh, now that's an emerging subspecialty of cardiology. So you've got the specialty of hearts, and you've now got the specialty of hearts in patients who've had cancer. Mm-hmm. And the reason for this is that the successful anti-cancer drugs damage the heart. There's a price of everything. Something good, something bad. And you must accept that all drugs have a side effect if they have a value. Mm-hmm. And the side effect of many of the anti-cancer drugs is attacking the heart, and they get heart failure. And indeed, heart transplants have been done on patients who've survived the cancer, particularly the young ones.
Mm-hmm. Amazing.
And this is now a new demand, and it's a new subspecialty, and you've got to monitor the heart carefully in patients who have these anti-cancer treatments.
Is that something you're working on?
No.
No.
Not me. I'm too old. I like my congenital hearts.
Yes.
That's enough.
Yes.
I've done my bit.
Would you update us with the services that are being provided in Mater Dei?
I think that you've got excellent services there. You've got a lot of intervention, opening coronary arteries, stenting them, which is probably the most important service because you've got terrible coronary artery disease here in Malta. You've got investigation of rhythms with my colleague, Dr. Aquilina, and you've got very nice equipment. You've got Gooch, I'm proud to say. They may not advertise it very much, but it's probably one of the best services in the Mediterranean, by the way. So be proud of it and promote it, and you might get patients from other countries. Who knows? Because it's a good service. What else have you got?
I'm seeing our credits coming up already. They're telling us we need to go. Please, would you pass on a message to our audience? I know you're very fond of Malta.
I love Malta.
I know you do.
I love
And you're
Malta.
coming back very soon again, aren't you?
Yeah. What would you want?
A message to our audience, to the Maltese people.
Thank you for always being welcoming, being lovely patients, being just great. And I have good friends here, and I love coming, and I love your sunshine. And you know, it's just as good as anybody else's sunshine, if not a bit better. I agree it's cold, but I love coming here. There are many things I love about it.
And I hope you see